Hey everyone, my name is Melody and I will be talking about diabulimia among type 1 diabetics and their access to good and quality healthcare. According to the vulnerability model discussed in Chapter 2 of our textbook, this population is particularly vulnerable to poor medical care as they experience barriers related to having a mental health illness. Our goal today is to discuss risks associated with developing diabulimia and how we can improve their access to medical and psychological treatment. So first off, what is diabulimia? Diabulimia is a restriction or complete omission of insulin in an effort to control one's weight. Diabulimia is when a type 1 diabetic omits insulin, making it possible for the body to process glucose, which is then excreted in the urine. This allows the patient to either avoid additional weight gain or lose weight. Signs of diabulimia often include hyperglycemia, a dramatic shift in weight, low energy, and the smell of ketones from the breath and urine, along with obsessive thoughts about their weight and body image. Diabulimia is often triggered as many patients tend to gain weight after receiving an adequate amount of insulin. Female adolescents are the most common population to be diagnosed. However, diabulimia also has other underlying factors that ultimately determine the patient's health status and health outcome. So what are some of the other underlying factors that may lead to diabulimia? According to the World Health Organization's Social Determinants of Health model, one's health status and health outcome is influenced by an individual's lifestyle behaviors, environment, and access to healthcare. Individuals with diabulimia are likely influenced primarily by their social environment and access to healthcare. Social factors may include cultural weight stigma, excessive dieting by peers, or bullying in school. In addition, stress may also be an important social determinant of diabulimia, as increased stress levels have been shown to lead to illness and negative coping mechanisms. Finally, individuals with diabulimia may also be affected by limited access to healthcare and health resources, which we will now discuss in greater detail. One barrier to medical care that an individual with diabulimia may experience is a shortage of trained medical professionals who have adequate knowledge and training to treat their condition. According to Chapter 2 of our textbook, this is a common struggle among individuals with mental health illnesses. However, this is often worse among those with eating disorders, specifically diabulimia. Treatment is difficult for diabulimia as it must involve a medical professional who is trained to treat both type 1 diabetes and an eating disorder. Treatment for these conditions often counteract one another, so it is necessary to find a medical professional who has the knowledge and training to treat both conditions. However, these trained medical professionals are extremely limited and scarce at this time. Another barrier to care may include the cost associated with treatment. Multidisciplinary residential treatment has been found to be the most effective for treating those with diabulimia. This form of treatment implemented therapeutic techniques while the patients simultaneously learned how to manage their insulin levels appropriately. Data from a recent study revealed statistically significant physiological and psychological improvement in most patients. However, although this form of treatment is effective, it is also very expensive, presenting a significant barrier for patients. Residential treatment costs on average about $30,000 a month and often do not accept insurance. But why? Why can't patients use insurance for residential treatment facilities if they have been proven to be effective in treating diabulimia? For one, insurance companies do not currently have a uniform set of criteria for coverage of eating disorders, including diabulimia. Reimbursement may be denied in general because the insurance company believes the patient can be treated at a lower level of care. Insurance providers often believe an individual with an eating disorder can treat their condition at home or with lower acuity outpatient services. Insurance providers often invalidate the needs of those with an eating disorder and reject coverage accordingly. But why? Why can't patients use insurance for residential treatment facilities if they have been proven to be effective in treating diabulimia? For one, insurance companies do not currently have a uniform set of criteria for coverage of eating disorders, including diabulimia. Reimbursement may be denied in general because the insurance company believes the patient can be treated at a lower level of care. Insurance providers often believe an individual with an eating disorder can treat their condition at home or with lower acuity outpatient services. Insurance providers often invalidate the needs of those with an eating disorder and reject coverage accordingly. So now that we know a little bit about diabulimia and the barriers associated with receiving good and quality health care, here are a few questions to think about. 1. What are the short-term and long-term consequences if someone with diabulimia does not receive medical and psychological care? 2. How can our federal government intervene and help alleviate the barriers to receiving medical and psychological treatment for mental health illnesses, including diabulimia? Thank you everyone for listening, and I hope this presentation was informative and helpful. Thank you.